should be in every block cart. It should be in every place that blocks are done. So that's something for you guys to check over here. Figure out where your intralipid is, okay? Pharmacy should renew it because it does expire. It comes in like a 250 cc bag. It looks like propofol. It's white, and we had them put a like a little cheat sheet right on top of it, sort of laminated on it. So it should come in that nice little package with the intralipid, the tubing, and the cheat sheet of how to do it. So make sure you guys, that's like your homework today, is go find the intralipid, figure out where it is, because it doesn't do any good if it doesn't, you don't know where it is. It is in the block cart that we have here, I know that for a fact. Over in the main OR, we have it in our block carts, we also have it in our Pyxis in the block room, and it's also in the core. So just knowing where that is. So basically, what do? Controlling, a lot of it's supportive care. So if they're seizing, control it with Versed. You always have Versed there, okay? Careful with things like propofol because the myocardium is already depressed. You don't want to send them into hypotension anymore. If cardiac arrest occurs, obviously do your normal CPR. It might take extended CPR. The doses of epi that you need are much smaller than you would use for a typical code. So we're talking less than 1 mic per kilo. So you're not talking these massive doses of epi. We don't recommend vasopressin. Obviously avoiding any calcium channel blockers, beta blockers, because again, that myocardium is already depressed. And then, as you know, the treatment for some ventricular arrhythmias is lidocaine or procaine. Obviously don't use another local anesthetic to treat ventricular arrhythmias, because that's what got us in trouble in the first place. But basically, the take-home message of last treatment is to get that intralipid, get it started, get it going. So here's, go ahead and flip. And obviously, you know, intubate if needed, CPR, all that stuff. So if you have a greater than 70 kilo patient, here's the math-free version of it. There's a milligram per kilogram that you do, but basically, hang it, give 100 cc's. Just let 100 cc's go in. And then you can figure out the infusion rate. So basically 200 to 250 cc's over 15 to 20 minutes. You can rebolus this. If it's less than 70 kilos, so, you know, obviously if we do peds over here, it's 1.5 cc's per kilo bolus, and then 0.25 cc's per kilo per minute of ideal body weight. Take home message, get the intralipid, spike it, hang it, and then take the time to figure out the calculations, okay? Again, it is not gonna hurt the patient. So just hang it, open it, get it into their system, and then calculate. Go ahead and...
Can I ask a quick question? Are our anesthesiologists and PAs, are they well versed in this?
Yes.
They're gonna know exactly if that's suspected what to do.
They should. Again, we do these department meetings. This is kind of, you know, but again, the signs and symptoms, the way sort of it presents, that just came out, you know, recently. So, you know, we don't all read all the literature, you know, all the time. So this is why we do these in services to sort of get the education out. But you might be the one, you know, you might be dealing with a surgeon who obviously doesn't read the anesthesia literature and doesn't think it's last, and you might say, no, I have a high suspicion that this is. I think, you know, we really need to get this in, get help, get, you know, an anesthesiologist there, and, you know, but it's important for us all to be, to feel comfortable as members of the team to speak up when we have a suspicion. Especially in a case like this, where the treatment is so benign, and the alternative is death. So, yeah.
I have a question. So do you see these signs immediately?
Good question. Not necessarily. Sometimes we do, okay? So historically, people got last because they injected straight into a vessel, all right? We are very careful to not do that nowadays. We aspirate at least every 5 cc's, and because we do things under ultrasound guidance, we're far less likely to get just straight into a vessel. So we're not going to get this massive just load into the vessel and like immediate cardiac collapse. That's kind of how it used to present. Now what happens is, you know, we're moving our needle around, we're aspirating, but maybe we, you know, we do get a little extra systemic absorption. Maybe we push into a vessel and inject before we, you know, aspirate again if we're moving the needle. So it can be a little bit more of a delayed response, or we completely miscalculate the dose and we give a like crap load of local anesthetic, and then it just slowly gets absorbed. So it can present, 20, 30, 40 minutes afterwards, just depending on the rate of systemic absorption. So again, just being kind of mindful of that. If you have a continuous catheter that's going, that can present at home. So, that's a concern with those.
How soon after you give the lipid emulsion does it start to improve? Should you
Pretty
start seeing
quickly,
something?
pretty quickly. Again, that's with, patients in full-on arrest. That's while doing compressions, that's while giving all your supportive care. But it should improve pretty quickly. Again, you have to give it time to get in the system to bind to the, that local anesthetic and to pull it out of the myocardium. But, it's not like immediate, it's not like Narcan.
But like within 30 minutes?
Yeah,
you should see
absolutely. Yep, and you can re-bolus too. If you've re-bolused a couple times and you're up to the max infusion and the patient still hasn't responded, think of other reasons. Maybe they just had a heart attack, or maybe they just had, something else. Think of other things. It might not be last.
And do you ever see this with liposuction, with the tumescent mixture,
Long after? I haven't personally. I think with the tumescent, there's a couple of things with that. Is a lot of it gets sucked out.
Yeah.
So, and fat is very avascular. So fat doesn't have a lot of the systemic absorption. They use epi, which makes it safer. You can use a higher amount with epi. It's a very dilute concentration of lidocaine, and a lot of it gets sucked out. So I haven't seen it, but now what we're doing, and I've gotten called, several times recently, hey, Dr. Littner wants to do liposuction with this amount of local, but Wyndham's also doing something that we want to tap lock for. Oh, and so we're starting to combine a lot of local anesthetics, and so it gets a little bit tricky with that. But no, I haven't seen it from lidocaine, but it has happened. There are certainly reports of last from tumescent lidocaine, so it does happen. I think our surgeons are very diligent here, but certainly it happens. So this is something that's really cool. So on your phone, there's these apps that Azra comes out with, and one of them that I love is the Azra Coax app. So Azra Coax app shows me when I can do a block. Now, peripheral block, I'll put a peripheral block in anybody. I don't really care about coagulation status. If the surgeon's going to cut on them with a scalpel, I can put a needle in them and feel very comfortable. What I won't do is a deep plexus block or neuraxial block. Spinal or epidural if they're anticoagulated. But what I have is this nice little coax app that shows me, and it's updated. So let's say I have a patient who's on Eliquis, and I don't know when I can do the neuraxial block. I can do it in 72 hours. So it tells me exactly when I can do the block. It tells me exactly when I can restart the anticoagulation, and this is updated by Azra and by the powers that be. Also in this Azra sort of bundle app is the Azra Last. So, and I have that on my phone, and it's a great thing. And this is what it does. So it basically takes you through a last situation. So begin last. All right, so let's say we suspect it, and it's timing you here too. All right, so have we stopped the injection? Do we get help? Get the code card. Consider lipid emulsion. Get it into the room. Call for last rescue kit. Consider alerting cardiopulmonary bypass. That is how we used to treat last. That's the only way we could treat last. Otherwise, you're doing chest compressions for days. Okay, you had to get that bupivacaine out of the system. The only way to do it was by bypass. It's still a consideration nowadays. So alerting CP bypass might be, something you can do. And then, okay, so then you do next. So we did all those things. And then it takes you through, okay, does the patient have a pulse? No. All right, begin CPR, check. Airway management, did somebody intubate? CP bypass. Okay, what's the rhythm? We're in VTAC. Okay, continue CPR, shock, advanced airway. Set patient weight, because we're gonna figure out our lipid. They're 80 kilos. All right, give lipid emulsion. And it tells you exactly how much lipid to give. It tells you exactly how much the infusion rate is, okay, based on the weight that you set. So this is a great app, and it keeps reminding you of what to do. So this is I know in code situations, my brain does the same thing. It like, you know all the steps, and then a code happens, and you're just like, ah! So this really helps you sort of like keep it all together. So it's a great app to have. I encouraged all of our docs to have it, all of our nurses to have it over there. It does cost a couple bucks.
$3.99.
Yeah, $3.99. So, but yeah. So get the app. They update it frequently with any new information, and so you can be assured that this is the most recent information on LAST. Go ahead, and all right. Any questions on LAST before we talk a little bit about Exparel? Right. Okay. And Janie, if you have anything to pipe in, go ahead and pipe in, because I'll just yap like you guys hear me. All right. So Exparel. It's funny, so today we are actually shooting a video. That's the only reason I did my hair today. And to impress you all, and for you all. But we're shooting this video for Operation Opioid Freedom. So we are representing today doing the 5 millionth patient to get Exparel since it was released in 2011. So pretty cool that we're a part of that, and kind of spreading the word about how to get patients opioid reduced or even opioid free. So we're going to shoot that later today. So kind of exciting that it's happening here at Wellstar. So what is Exparel? Exparel is basically bupivacaine that's encapsulated in these liposomes that are biodegradable, and once they're in your body, they slowly sort of degenerate and release that bupivacaine slowly over the course of about 72 hours. So this is the label on the FDA. This is what it's indicated for. It is indicated for single dose infiltration in adults, so over 18, to produce post-surgical local analgesia, and as an interscaling brachial plexus nerve block to produce post-surgical regional analgesia. So that is what is on label. So it can be used in surgical infiltration. So surgeons can use it in field blocks. We can use it in fascial plane blocks, PECs, TAPs, QLs, erector spinae blocks, fascial IACA. All those things are covered under the label. As of April last year, after a huge fight with the FDA, which I was a part of, better for worse, we did get the indication to do brachial plexus block, so an interscaling block. It is not on label to do any other nerve block. It is not on label to do pediatrics. What does that mean? Nothing to us. We use things off label every single day. Whenever I do a spinal for a total joint, which we do how many times a day? Lots. I'm using bupivacaine. That's off label for spinal. Okay? It says on the jar, not for spinal anesthetic. All right? I know that it's preservative free. I know that they're not going to test bupivacaine in every single nerve of every single body to get FDA approval. Those studies are expensive and time consuming and a pain in the butt to deal with the FDA. So we use things that we know are safe. We're aware of the pharmacokinetics and pharmacodynamics and the way they interact with the body. I use this drug everywhere. I do all of my peripheral nerve blocks with it. I do it in patients younger than 18. Now, in really little patients, I don't yet because they haven't released the dosage requirements. Anybody over 18, it's not weight-based. So even if you have your little 40-kilo elderly lady, they can still get the full dose of Exparel. That is not weight-based. But when you're talking about your little kids, we don't really know the dosages yet, so I don't use it in the littles. People do across the country at major pediatric hospitals. They've kind of come up with their little spreadsheets and stuff, but we just don't use it here yet for the littles.
So what are you talking about as far as age-wise?
So we'll use it, I've used it on, all teenagers, because most teenagers honestly weigh 3 times as much as I do. So I have no problem using it on a 14-year-old that is sort of a normal weight.
Right.
Now, if you've got, a 10-year-old, okay, that's a different story. But I don't want to be involved in the 10-year-old anyways, because that's so there's 2 vial sizes. They always make fun of me, Janie, because I always come over here and whenever I have the peds room, I'm in such a bad mood in the morning. I'm like, oh, I hate this. So anyways, there's 2 vial sizes. There's a 20 cc vial, which is 266 milligrams, and there's a 10 cc vial, which is 133. I don't even think our hospital has the 10 cc vial. That would really be used if my husband was doing an infiltration in the hand, he might use a 10 cc vial. There's no need to put 20 cc's in the hand. I don't know where to put it. Some people use a 10 cc vial for the inner scaling because that was what was studied in that pivotal trial that went in front of the FDA. I don't. I use the 20 cc's. If I'm going to give Exparol, like, go big or go home. But really the choice depends on the size of the area to cover. So if somebody's using it for a small little hemorrhoid, again, they might use the smaller vial. But again, I don't even think we have that, just to let you know there are 2 vial sizes available. Okay, so this is the pharmacokinetic curve. So because I'm a nerd, this is like my favorite slide, but you guys are nerds too, so we're all in the same company. But basically this shows me sort of the safety. This does not tell me anything about clinical efficacy. We can't do that with local anesthetics. It doesn't work that way with this PK curve. But what this shows me is safety. So here's time, and then here's the plasma bupivacaine concentrations. So what Exparol does is it has this little bit of extra liposomal bupivacaine, and then it just slowly releases up to peaking at about 36 hours, between 24 and 48. And it's a little bit different depending on where you inject it, okay? Peripheral nerve versus field block versus fascial plane block, that's gonna vary a little bit. But what I want you guys to notice is the Cmax. So what I care about in anesthesia is the Cmax, which is this peak right here, okay? I don't really care how long it lasts. What I care about is that peak level of bupivacaine. How high does it get? Do we have another slide that shows like the, yeah, this one, okay, all right. So how high does it get? This is done in the peripheral nerve blocks with the 2 different vial sizes, the 10 cc vial and then the 20 cc vial. If you look at infiltration, it's roughly the same. It's actually a little bit lower with infiltration, a little bit higher with the nerve block. But what I want you to see is the Cmax, the maximum concentration, when I'm using that full 200 cc vial or 20 cc vial, is 460 nanograms per cc, okay? Right here. What does that mean? That means it is super duper safe, because when we're talking about last, when we're talking about the concentrations of bupivacaine that are needed to induce last, we're talking about 2,500 to 4,000 nanograms per cc. Way up there, not even on this graph, okay? So if I give that full-on dose of Exparol, the maximum I'm getting is 406. That's my Cmax. Not even close to where we would get last, okay? They have given like vials and vials and vials of this stuff to patients, and they don't induce last. They have actually injected it into veins and arteries in dogs, because you can't do those studies in humans in America. But they've done it in dogs, like trying to induce last, and like they can't get there. So it's very, very safe. We don't really know why. Part of it is because probably the liposome probably is protective in itself, and it just doesn't release all that bupivacaine right away. So it's just this slow, sustained release. If you look at what regular bupivacaine does, there's a peak right here. It goes like this, up and down. If you look at catheters, they get pretty high, and that's, again, you always have to be a little bit cautious sending patients home with catheters. It's a continuous infusion of a cardiotoxic substance around their nerves, and they're at home. So go back a little bit, but again, just showing you how safe it is. Yeah.
Now, I've seen doctors dilute the Exparol
Yes.
in marking.
Yes,
the safety
absolutely. It's like I planted you, Megan. That was my next slide. Okay, go ahead and all right, perfect. So now, when we literally first got Exparol, we had no idea how to use it. It just like showed up at our pharmacy, and we're like, oh, cool, Exparol. We literally took it straight up and like put it in the posterior capsule, and it didn't work. So Exparol, you have to, in a field block. In a nerve block, it's different, but in a field block, Exparol stays where you put it. Okay, so the injection has to be a lot more meticulous if you're doing a field block. Bupivacaine will spread a certain, amount in the tissue. The Exparol does not. It stays there. So 2 ways to get it to spread. One is more injections, which if you're doing a field block, you're going to have to do. With our fascial plane blocks, the way we do it is we just move our needle like in that fascial plane and get it to spread. And then 2 is volume. Okay, so you'll see, like, if you do a thoracic case with Dan Miller, don't you miss those, Megan? Yeah. If you do a thoracic case with Dan Miller, he uses 200 cc's of volume to do his intercostal blocks. Now, only 20 cc's is Exparel, and a small amount is bupivacaine, and the rest is saline. But saline will help that Exparel get to where it needs to be. The other thing that we do and that we recommend is admixing it, okay? So as you saw by that curve, Exparel takes a little bit of time to come on. So if we do a field block or a nerve block with just Exparel and saline, they're gonna be hurting in the OR. They're gonna be hurting in recovery. They're gonna think the block didn't work. It's not that the block's not working, it's just it hasn't kicked in yet. So we need something to sort of kickstart that block and work before that Exparel comes on, right? So that's why we mix it with bupivacaine. So that is why you'll see it being mixed with bupivacaine. Now, a couple little caveats here. Bupivacaine is the only local anesthetic that you can mix in the same space as Exparel. You cannot mix Exparel with lidocaine, chlorprocaine, ropivacaine, anything else. Those local anesthetics will affect the integrity of the liposome and will cause a massive release of all the bupivacaine in that Exparel. So very, very important that you do not combine those. Now, what about, okay, we did a TAP block, and now the anesthesiologist wants to give a little lidocaine IV on induction, as we always do. That's fine. It's not in the same site, right? We did a TAP block, because Wyndham did a hysterectomy, and somebody is also taking out like a little lipoma or something on an arm. They can use whatever they want here, as long as it's just a small amount, and as long as we are aware of the total amount of local anesthetic that we're using. And if you guys ever have any questions, like, hey, is this kosher? Is this too much? I get texts all the time. You can text me, you can text Jamie, we can help you figure out, total amounts, because it is a little bit tricky to try to sort of incorporate Exparel into that calculation. But again, it's a different surgical site. But in the same surgical site, you can only mix Exparel with bupivacaine. But what that bupivacaine does is it comes on quickly, so that block sets up. By the time the bupivacaine's done, that Exparel is kicking in. So it's this beautiful little, like, immediate and long acting.
And it has to be plain.
It doesn't have to be fine. You can use it with
You
that.
can use
Yeah.
it with
Yeah.
that.
Good luck finding that in the hospital. We can't get it in the blocker, but
Day to day.
day to day. So yeah, no, it's fine. It's been tested with epi, with Decadron, with morphine, with all kinds of stuff that's safe. But as far as local anesthetic, it's
So
just.
do you mean with mixed, a separate injection of just the bupivacaine? They can use it in that area? Or it's physically mixed with the extra?
Either or.
Mixed.
Either or.
Yeah.
Doesn't matter. You can mix it or you can inject it separately.
Okay.
You can, I have a colleague up in Minnesota who does all of his blocks. He'll inject the bupivacaine first, and then he'll like chase it with the Exparel.
Okay.
We mix ours all together. So we mix Exparel and bupivacaine in the same syringe.
So that's something you guys would do before the surgery?
Yeah, now if the surgeons are using it, we're not involved in mixing it.
Okay.
They would ask for, Exparel and Marcaine, and they probably, like, what they do in the main OR is they just, like, shoot it into a little Edison basin,
Yeah.
essentially, and they draw it up, okay? But just making sure that you're staying within the limits. So
Okay.
there is a ceiling of how much bupivacaine you can mix with the Exparel, okay? Everybody ready for a little math? Okay, so let's take a 20 cc vial, since that's all we have at the hospital. 266 milligrams of bupivacaine. That is the molar equivalent to 300 milligrams of bupivacaine hydrochloride. You can mix Exparel to bupivacaine in a 2-to-1 ratio. So if you have 300 milligrams of bupi hydrochloride, you can use up to 150 milligrams of regular bupivacaine, or bupi with epi. All right, 150 milligrams. What does that mean? Cliff Notes, math-free version. Up to 30 cc's of 0.5% bupivacaine, or up to 60 cc's of 0.25% bupivacaine. Does everybody know how to convert percentages of local to milligrams?
No.
Okay. So all you do, you just move the decimal place over. 1. Okay? So 0.25% bupivacaine is 2.5 milligrams per cc. Move the decimal point. 1. So 0.5% bupivacaine is 5 milligrams per cc of bupivacaine. Okay? So that's how you figure it out. Simple, stupid way. So, but just sort of remember, 150 milligrams with that 20 cc vial. If you're using a 10 cc vial, it's 75 milligrams. So if you do see that, it's just cut in half. And then this is how much you can use. So this will give you, if you mix that, it'll give you 50 cc's total. If you mix this, it'll give you 80. Now, if you need more volume, add saline. Right, and that's what, Megan, you've seen in the past too, okay? So some surgeons need more volume. When we're doing our TAP blocks, we need more volume. We add saline. You know, when we're doing, again, a lot of those big local infiltrations that the surgeons do, like, you know, like Dan Miller does with the intercostals, again, he adds saline. When our surgeons are doing periarticular injections for total joints, they're adding saline because they want that volume, okay? So they can always add as much saline. You can go up to like 360 cc's total. I don't know where you would put all that, but you can do that. It does not dilute the Exparel, that saline. It will dilute the bupivacaine, you know, that's how you dilute bupivacaine. But all it does with the Exparel is it just helps it spread to where it needs to be, okay? You can't go over the ceiling, not because it'd be toxic, but because, again, over the ceiling it interferes with the integrity of the liposome. So just kind of stay, you know, within that and be cognizant of that. Questions about that?
Sorry.
No, good.
Now, like with JP's patients
Yes.
downstairs, I knew that we started doing the blocks
Yes.
before,
Yes.
and then he was still using local on
Yes.
the field.
Yes.
And like you had recommended that we didn't need to.
Exactly.
But he said that the patient still had pain or whatever.
Right.
That's because it hadn't kicked in yet, or because we didn't use local on the field.
That was when we first started doing these, and we just weren't very good at TAPs. Yeah, there's a learning curve to all these blocks. So regional anesthesia is kind of this funky field. It's the fastest growing field of anesthesia. It's still in its infancy. So ASRA, which is our big, you know, national meeting, literally even like 5 years ago, it used to be just like, you know, a few hundred people there, and now it's like 2,500 people. And you'll go and, you know, you go to these internal medicine meetings, and there'll be this massive study of 50,000 patients across 32 different centers across, you know, a decade, and here are all the results, okay? You go to ASRA, and it's like, hey, so last week I did 2 patients, and I like invented a new block, and this is what I found. I don't really have any data. I don't really know how it's gonna go. I'm probably gonna create a new, like, you know, part of it next week, but this is what I got now. And everybody literally goes home and tries it. So it's that on the cutting edge. That is regional anesthesia. That's what makes it so exciting to us. And it's really such a great way that we can control patients' pain, but there are new blocks turning out every single day. My partners hate it when I go to conferences because, and Janie knows this, like literally I will come back and they're just like, oh, I hate it when you go to conferences because you come back and you want to change everything and we have to learn new stuff. I'm like, that's progress, that's medicine. But basically that's what happens. So when we learn a new block, there's always a learning curve. And our surgeons are used to that now, and they're willing to be patient with us because they've seen the results of once we do learn the new block, it's very effective. So with JP's patients, he no longer injects. We cover the entire abdominal wall, so they don't need to inject. If we do like an interscaling, I went through this whole thing with Starnes because he was still injecting local. I'm like, this arm will be blocked for like 3 days. There's no reason for you to inject a local that's gonna last for 6 hours. Mine's gonna trump yours, right?
Right.
It's unnecessary and it's covered. So we've, you know, slowly but surely getting there. So yeah, typically when we do a block, it's unnecessary for the surgeons to add more. Now we do have some cases where that is the case, and we account for that and drop our bupi dose. So for example, in the GYN cases, oftentimes the patient will be having a hysterectomy and will have, you know, the ports that need to be covered. We'll also be having some sort of like rectocele, cystocele down there. I don't cover down there. So I'll drop the amount of bupi I have and give them that amount of bupi to use
On the field.
on the field.
Okay.
So that's what we do. But we're pretty cognizant of where the pain's going to be and where the incisions are going to be. And we'll give the surgeons extra local if we feel like they're going to need it. But typically if we're doing a block, we're basically covering that whole area. Yeah, but good question.
I have a question. How do you determine who gets Exparel and who doesn't?
Great question. Okay, so my job as a regional anesthesiologist, or really just as an anesthesiologist in general, is I have to consider the expected pain burden duration, okay? And I have to match that with my anesthetic and analgesic technique, right? So if my husband's doing a little dinky case that's gonna hurt for that day, he can inject local, just regular old bupivacaine or ropivacaine or whatever on the field. They need it covered for a few hours. It's not gonna be that painful. They can go home on Tylenol and Motrin and be absolutely fine. That's not a case where I would use Exparel, because Exparel is pricey, okay? But if I have a total shoulder, that pain is gonna last for a number of days, okay? I need to make sure that my analgesic technique matches that duration of pain burden, okay? So I'm gonna choose something that's gonna last for that number of days. Exparel will be a great choice there. So it's all about sort of matching that and doing that. Yeah, Exparel, speaking of cost, so it's about $300 a vial. Wellstar gets it for $285 a vial because we do use, quite a bit of it. And it's difficult because it comes out of the pharmacy silo and they kind of make the most noise about drug costs. We actually, Janie and I just submitted a study to ASRA that looked at doing a single shot interscaling block with Exparel versus the way you used to do it with catheters. And the Exparel injection is way cheaper than doing the catheter. When you consider all the supply costs. Now, not all of that is pharmacy costs, they just tend to be the most vocal about it. So just because we're using Exparel doesn't mean that the cost of the entire episode is higher. In fact, oftentimes it's considerably lower in less time as well.
So, is Exparel sometimes covered by insurance or is not at this point? Because every time
Right.
I've had it either, well, really for my family, it's
Yeah.
not covered.
Yeah, so it just depends. And I think you're gonna see it being more and more covered, and I am not the person to ask about that stuff because I don't understand. What I do know is that it is being bundled with things. So like Aetna and I think Humana have now started bundling in their outpatient ASC like total joints. It's in that bundle, so it's covered by that bundle. A lot of oral surgeons are getting it covered because that's the highest rate of opioid addiction in young adolescents is getting your wisdom teeth out. So, but sometimes it's not, and they're just offering it to the patients, and if you want to pay for it. I think you're going to see it more and more covered. If you're getting it in the the main OR, again, it's just another drug that's added, and is Tylenol covered? Well, it all goes into that thing, and then the insurance pays a certain percentage of it. It's not like they don't cover that drug. It's just that they pay a certain percentage of the whole thing. It's kind of what Wellstar wants to charge. I mean, Wellstar can charge $10 million for a rectal Tylenol, like do. But but it doesn't mean that you're gonna get set with that $1 million Tylenol bill. Like it all goes into the insurance and they pay a certain percentage of it. But it is being more and more covered, and especially with these partnerships, like Aetna has partnered with Pacira, the company that makes this drug. So a lot of like Aetna covers it. And now with all this sort of fighting the opioid crisis, business that we're doing, you're going to see it more and more covered. Yeah, exactly. And we're hoping to sort of change the mindset that is just this like super expensive drug. We're trying to show you that this is a great alternative to opioids, and actually, if you look at what it can do, it can save you money in the long run because you don't have all the side effects.
Like for the oral surgeon,
Yeah.
it was $255
Yeah.
for the Exparel
Yeah.
versus $5
Yeah.
for some hydrocodone.
Yeah, exactly. So hey, $5 for hydrocodone that I can also sell in the street and make more money versus $300 for the Exparel.
Yeah.
But you have to look at it long term. First of all, is hydrocodone even needed for wisdom teeth? Okay, no, it's not. They shouldn't get it. I remember getting my wisdom teeth and I got 2 ice packs and an ace bandage, and I looked like Jacob Marley from Dickens. But it's I think we're way over prescribing. That goes into a whole different lecture that I can give. But again, it's risk benefit because we know that that's one of the leading causes of creating addiction in our young adolescents is just oral surgery. So it's causes readmissions, it causes opiate adverse related side effects, all that stuff. So yeah.
Thanks. So, you say that Exparel lasts for 3 days.
Yes.
What is their pain reaction after that wears off?
Great
Does it
question.
go from like a 0 to 100?
Great question. The nice thing about Exparel is that it wears off slowly. Okay, and I can tell you that because I had a top lock with Exparel, and I cannot tell you even the day that it wore off. Because I was like, I'm having a little bit more discomfort, then I'd scratch my belly and I'd still be numb. So the 2 things that people hate about nerve blocks. One is if it's a peripheral nerve block, they hate the motor. They hate the fact that they cannot move their arm. Exparel has, it's not as dense. So the motor comes back quite quickly. And they don't have that significant just like dead arm feel. The second thing they hate about it, and what we all hate about it, when Janie hates about it, when she gets phone calls, is, hey, my block wore off at 1:42, usually a.m. Usually it's always in the middle of the night, right? Like they can tell you on the dot when that wore off. Exparel does not act like that. It's a slow offset, which is really nice. So by the time that wears off, you don't get that rebound pain, which is nice. And again, because we're trying to match that pain burden to our local anesthetic, we're hoping to get them over the hump, which is kind of that worst part. And because we do it preemptively, we're blocking that pain cycle from even starting to rev up. And so we're reducing the amount of pain that they're gonna have overall anyways. So it's just overall better control. Now I will say, Exparel's not the be all end all. Pain blocks are not the be all end all. Everything works together. It's in the background of a robust multimodal protocol. So if you look at like our total joint patients or our abdominal surgery patients, they all get standing Tylenol, standing Celebrex. Like our total joints patients get Celebrex for 2 weeks, twice a day. They get gabapentin 3 times a day for 2 weeks. They get the Robaxin as needed. They get this. The opioid is just used as needed. A lot of the other drugs are standing, okay, where they're given, on a schedule. Blocks are part of that multimodal, okay? Okay, go ahead and flip. So these were questions that our group had when I gave this talk to our department. These were things that they kind of wrote in. I think we've covered most of these. This was just a motor block. No, we see varying levels of motor blocks with our peripheral nerve blocks, but it's really just not quite as dense. Can I use intralipid to treat a last event with Exparel? We don't know that yet. And honestly, part of it is because there really aren't many case reports. Exparel's been used 5 million times. There's 66 case reports that involve Exparel that have gone on to last. But I will say, all of those 66 also gave like a crap load of bupivacaine or some other local anesthetic. So my guess is the last event was not from the Exparel, but rather from the crap load of other local anesthetic that they gave, okay? So if you get last and you've given Exparel, give intralipid. We don't know how it really interacts with that. Those studies are being done right now as we speak. But it's probably not due to the Exparel anyways, it's probably due to the other local anesthetics, so give intralipid and it will treat that. I think we've really covered most of those that are relevant to what you guys do over here. Any other questions?
I have one question.
Yeah.
I'm sorry, I have a lot of questions. So for our purposes here, the blocks we do, and I don't mean it in a bad way, but sometimes we go in a room and the docs are kind of training to do a block. So they just kind of talk and do a lot of different things, which, but the patient comes to recovery and they're hurting 10 out of 10 and they want, I know
Yeah.
Dr. Holtz is, bless his heart, we bring them into the room, they're screaming,
Yeah.
does that mean the block didn't work?
If it's not working by recovery and they have no motor block and they mixed with bupivacaine, correct. And so if that happens, I need to know who those people are so I can retrain them. We try to, we have 30 physicians and we have 9-ish that do blocks. So we have a set number of block docs. And I actually would like to shrink that to get people to be more expert in it. The problem is I need those people in the main because we do 800 blocks a month in the main, which is why they never let me out of there and I never get to see you lovely people anymore. But so when somebody needs a block over here, it's like trying to get somebody deployed over here to do the block. So I apologize, it's not the best process. We're trying to train more people to sort of just do the basic blocks. Over here, it's the basic blocks. It's nothing fancy schmancy. It's the basics, right? So we're trying to get people trained on that. If you're seeing blocks that don't work, I need to know about that.
It's still not the same standard of care.
Right. Yeah, I mean, I agree. So, but, the alternative is train every anesthesiologist to do blocks. I'm totally against that. I think it needs to be specialized. There's a reason there's fellowships for regional anesthesia. You wouldn't certainly want to show me like how to do a cardiac case that I haven't done since residency and say, hey, go up and, you know, work with Cooper or work with, you know, Rich Brown. No, bad news. Bad things would happen, okay?
Yeah.
Same thing, there's a reason there's a fellowship for cardiac anesthesia. There's a reason there's a fellowship for regional anesthesia. It's a whole year beyond, you know, what you get in residency. So, you know, it's difficult. We're trying to train, you know, more people. We're also trying to get people coming out of residency and fellowships with these skill sets. Because regional anesthesia is so new and so, you know, evolving, it takes people to be committed to wanting to learn this, yeah. So we're getting there. I know it's not the same. We really try to send people over here that know what they're doing. The problem is a lot of it is posting. We don't know until the KOP AOD calls us and be like, hey, there's a patient over here that needs a block. They're going back in 20 minutes. Okay, totally news to us. Like, we need to create a better process so we know that ahead of time so we can adjust and maybe have a block doc actually over here that day, you know, doing cases and then get relieved to do that. Because getting notified when I have, you know, 4 block bays completely full in the main OR, I can't send anybody over here.
What about,
But it's usually on the, it's listed as a block on the schedule.
Sometimes, not always. We get a lot of surprises.
a lot of Dr. Holt's,
Yeah.
those ones that happen overnight,
Yeah.
the ORFs that fall at the bottom of the schedule
Yeah.
for us,
Yeah.
they're supposed to day before, and that doesn't always.
So that's something that we need to get with, the KOP AOD needs to be taking care of that, needs to take responsibility for that. Making sure that they look at the schedule the day before, figuring out if there's any blocks, and kind of, you know, working with Janie to try to make sure that everything is
By
covered.
that time, the regular AOD's gone, and
Right.
it's the guy, whoever
Sure.
is coming out of the
Sure.
room and just gonna
Exactly.
watch the board for a couple
Yeah,
hours.
so we're working on process improvement stuff, you know, in the main OR, so this is something that we could probably add. We could talk to Anil and see if he can come over here and try to help us figure that out. I think that would be a good solution, because again, it's a process thing. We do not have, logistically, we cannot deploy somebody the last minute. Just can't do it. So we need that lead time to be able to do that. So, I guess law head's in charge over here, right?
Yeah.
Okay, so we'll, you know, talk to law head and get him on board. It's tough when you have people that don't do blocks, they don't understand kind of the,
Now, Maggie, what about the surgeons that do their own blocks?
yeah,
Dr. Russell
yeah,
specifically.
yeah.
He doesn't come over here for whatever reason, something to do with the blocks, when we could be doing a lot of his cases.
Yeah, so we do all of Russell's cases, we block all of his stuff in the main
'Cause he
OR.
said he could do his own blocks.
He doesn't do it. He has us block a freaking toe. You know, like,
Okay,
yeah.
well, thank you for
He could, yeah. No, if he wants to come over here and do his own ankle blocks, he just would prefer us to do it.
Okay.
We can do it over here. It's just, you know, logistically it's a little bit more difficult.
Right.
So I think that's why he posted it. It's just easier for him to get it done
Okay.
over there. Yeah. And historically, we couldn't do catheters over here because of the
Well,
billing.
yeah, but he uses the IQ. that's
Right.
all.
Well, no, now we use Expert for his patients.
Okay.
So historically, like, even Danny would a lot of times post his distal radius ORIFs for the main because he wanted the patients to get a catheter. And we couldn't do that over here because of billing something or other. I was told no catheters over here. Now that we're using Expert, we can. So that shouldn't be a limiting factor to Russell doing. Well, I will say that a lot of Russell's cases don't need a real peripheral block. He can do an ankle block.
Okay.
So, and that's just, you know, his whole thing in the OR.
That's both sides or there's none?
Yep.
Yes.
All right, Jeannie and I have to run back and